All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedules to this video will be available for review after this journal club. The information contained in the video content represents the opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content which is provided as is and without warranties. We are looking for a sports medicine physician in our team. This is a full-time clinic-based physician working in a sports medicine clinic. Please feel free to pass our information along if you know of a qualified candidate. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Dr. Uziel Sauceda is the current program director of Riverside University Health Systems and University of California Riverside Sports Medicine Fellowship. He completed medical school at the David Geffen School of Medicine at UCLA. He completed his family medicine residency and primary care sports medicine fellowship at the University of California, San Diego. Dr. Sauceda is involved in ringside physician work with both CAMO MMA and USA boxing. Today, he will be presenting on abdominal injuries in athletes.
All right. Let me see. Can you see my screen here?
Yes, we can.
All right. Oh. Do I get rid of this little thing here?
There is a little orange arrow that says
hide
channel.
Got it.
And we'll have you take it away.
Sounds good. So we're going to talk about abdominal trauma. And this is my conflict of interest statement. I have no financial relationships. And basically, we're just going to get started with the basics of the abdomen, common mechanisms, and my outline is here. Most of the time for abdominal injuries, they're not all that common. So we're going to go over the most likely organs that are going to be injured, and a little primer on mononucleosis and what that implies in terms of risk of abdominal injury, and then return to play decisions. So when you think about the abdomen, there's a lot of stuff going on in in that belly. So the best way to think about the abdomen and trauma is to think about the intraperitoneal space and the retroperitoneal space. And if I have a laser, hopefully you can see this laser here. This is sort of an axial image here where you can see both kidneys here. The retroperitoneal space is basically anything that is behind or posterior to basically the peritoneum. And the peritoneum contains all the visceral organs, meaning namely the intestines are the main visceral organs, and the liver is also intraperitoneal. So retroperitoneal organs are by definition more anchored onto the body, and therefore they can actually feel more of an impact from an abdominal injury. So in terms of the anatomy, we have the intraperitoneal organs, the stomach, the liver, the gallbladder, the small intestine, the large intestine, the bladder, and for females, the uterus and ovaries. And retroperitoneal organs are the kidneys, the aorta, the pancreas, the adrenal glands, and the spleen. Now, the most important organs, I would say, would be the liver and the spleen, because these two organs have relatively the largest vascularity, and really the bleeding risk is the highest when you injure these two organs. So these two organs are most at risk of causing hemorrhagic shock. The intestines, such as the duodenum, jejunum, ileum, and the large intestines usually don't get injured all that much with low energy trauma. It takes a really high velocity injury to cause a viscous perforation. The left hemidiaphragm is susceptible to tears and herniation, especially with someone who has predisposed, hiatal hernias or any additional amount of pressure in the abdomen. Aortic transections are not seen in sports, at least not the collegiate sports that we're used to. This can usually happens from sudden deceleration in motorcycle accidents. So when it comes to motor sports such as motocross and high-speed velocity racing sports, you can think about that. Partial tears are usually survivable, but complete tears are usually not. Kidneys do have a lot of lacerations when they do get injured, and sometimes there's rib fracture implicated in that. Again, pelvic organs are usually shielded from injury from trauma. However, if you have a fracture, that can definitely affect pelvic organs more. So, as I mentioned before, abdominal injuries are kind of rare to see in sports, but when they do happen, it will be in the mechanism of collision or in a contact sport. For splenic injury, approximately 25% happen with blunt abdominal traumas, and liver injury is 15 to 20% of abdominal trauma. If there is indeed a liver injury, there is a high risk of death. Approximately 50% of deaths due to abdominal trauma happen because of a liver injury. So these are high-risk sports that are implicated, and this may not come as any shock or surprise to my audience. Skiing and snowboarding, you can really pick up speed going downhill. Both bicycle and motorcycle events, especially for bicycle, if you're going downhill, you can actually pick up speed pretty quickly. Equestrian events, if you're basically either fall from a horse or you're going on a full sprint and then something happens where you kind of lose it, or there's a failure of the equipment, you can have high velocity injury there. Football is one of those sports that is implicated in abdominal injuries, mainly because of the contact is willful tackling. And mountain climbing, mainly from falls from significant amount of height. And you can either fall onto the ground or you can fall onto the side of the cliff, even though you're strapped on with your ropes. The impact onto the side of the cliff can be enough that you can cause an abdominal injury. So when it comes to bicycle and motorcycle, the deceleration really has a lot to do with the risk of handlebars. The handlebar trauma has been known to be like the main culprit, which can lead to liver tears, subcapsular hematomas, sometimes pancreas transection, and small bowel evisceration if you basically have penetrating trauma as well. Deep dives, meaning if you actually do dive past a certain amount of meters, that could induce barotrauma into the abdomen as well. So if you're an athletic trainer or you're on the field and someone comes up to you and says, hey, this guy has abdominal pain, it's important to know how it happened, because you can think about, if there was trauma, you can triage the patient slightly different than if there was less trauma or low velocity trauma. So usually you want to find out how the direct blow to the abdomen happened, or if it was indirect blow. So a direct blow usually will be affecting more the abdominal wall or the chest wall, whereas a sudden deceleration can affect more visceral organs. Again, remember where you're at. So if you're covering a lot of motocross and sports as such, see if there was any handlebar trauma, player contact, football tackles, or direct blow to the back or the flanks. Start thinking more of kidneys at that point. So again, with any kind of trauma, you want to go back to your basics, right? So if you think that there's a C-spine problem, you want to secure the C-spine and the breathing before focusing on the abdomen. So if you understand the mechanism of injury and there was no chance that there's C-spine trauma, then you can, proceed to do a focused exam onto the abdomen. So there are signs of intraperitoneal and retroperitoneal bleeds or pelvic fractures. This probably won't apply to you in the field, but sometimes there could be blood at the urethral meatus or bruising. You're not going to uncover the athlete unless it's truly quite an emergency. The sequence of examination is usually inspection. Make sure you can observe and see if the abdomen is protuberant, palpation to see if there's a lot of abdominal tenderness. You can percuss, and if you have a stethoscope, you can auscultate. Auscultation sometimes is low yield in terms of abdominal trauma, but if you follow that sequence, you at least won't forget to fully examine the patient. So severe ongoing pain and signs of hypotension are things that really require immediate transport to the emergency department, because that would indicate fairly large volume of hemorrhagic loss into the abdomen. So if you have a high velocity event, usually there's EMS on site, and getting venous access at that point would be of paramount importance. They can start IV fluids on the way to the hospital. Sometimes nasogastric tubes and urinary catheters are needed. This is usually done at the hospital site. And then serial examinations while you're admitted to the wards are very important, just to see if you have a CT abdomen and it shows a small amount of bleeding either in the abdomen or retroperitoneal. You're not going to keep scanning several times. The utility of that is kind of overkill. So usually serial examination is enough, and if something changes, then you scan. So let's say you're on the field and you think patient needs to go to the hospital. It's a good idea to see if you can alert the emergency department prior to the patient arrival, especially if it's a pretty significant trauma, high velocity trauma. That way the hospital is prepared to have a trauma team ready. And sometimes you can prevent death from hemorrhagic shock that way. So what happens in the hospital? The doctors will do what we do, and we'll order a bunch of laboratory tests, get complete blood count, metabolic panel, creatinine, BUN, glucose. A helpful test is called amylase. Amylase is an enzyme that comes from the pancreas, and it can detect pancreatic injury. It is best used 3 hours post-injury. So if it's elevated, that is a sign that there's a pancreatic injury from the abdominal trauma. And a urinalysis looking for hematuria also is a sign that if you have blood in the urine, that you may have damaged the kidney or the ureters from the abdominal trauma. In terms of imaging, the best imaging in terms of quickly determining whether you have an abdominal hemorrhage or not is called the ultrasound fast or focused assessment for trauma. And this detects fluid inside the abdomen, meaning the intraperitoneal space. And presumably, if you see fluid, that is blood until proven otherwise in the setting of an abdominal trauma. Many emergency physicians are quite skilled at doing this fast exam, and the acronym sort of fits because you can find out quickly if the patient has bleeding in the abdomen or not. After you confirm that, then a CT abdomen will basically locate where the bleeding is coming from, most likely. It's usually implicated to be either a liver laceration or sometimes the spleen will start retroperitoneal, but you never know. Sometimes it can connect to the peritoneum as well. Back in the 90s, where this paper was written, there used to be a lot more utility to doing a diagnostic peritoneal lavage. This is where you put a needle through the belly and push fluid and then bring the fluid out and analyze it and see if there's blood. That would be a relatively quick way of seeing if there was some bleeding in the abdomen. But this is no longer routinely done since we have ultrasound. So it's been replaced. So for the treatment of a hemoperitoneum, you can choose surgery or not surgery, right? So it depends, right? So for a ruptured spleen in children, most of the time, children are pretty good at maintaining their blood pressures, and they can manage non-operatively with serial exams, serial monitoring. Surgery is usually done in patients who can't hold their blood pressure in a hospital setting. There's other signs such as tachycardia, abnormal hematocrit. This indicates significant amount of bleeding sufficient to negatively affect organ perfusion. So at that point, the type of surgery is basically an exploratory laparotomy. They just do a big, large midline incision and find out where the bleeding is coming from and control it. And that's general surgery's turf. So that was a brief overview of what kind of what happens with an abdominal injury where an athlete sort of has to go to the hospital and ends up getting treated there. Now we're going to look a little bit more closely as to the types of abdominal injuries. So MSK injuries for the abdomen, most of them are contusions and they're low level and they're self-limited. These are usually happen from football mainly. I've seen football have just abdominal contusions from tackles or dog piles and stuff like that. So that's usually fine. There is one type of MSK injury that can result in a surgery, which is called a rectus sheath hematoma. This is a very large collection of blood within the abdominal wall, and this is from an epigastric vein or artery rupture from trauma. I have not seen one of these in person, particularly myself, but if they get large enough, they may require surgical ligation of these of the artery or the vein. Rib fractures as well, they do happen, and this is from direct blow or fall onto the chest wall. Usually there's not a lot of collateral damage. The most important thing is to find out if the lung or the abdominal organ was either damaged by the fractured rib. Usually the patient does not need surgery, they heal in time, and you just want to manage their pain in terms of every time they take a big deep breath inside, there's going to be some micro movement of those fractures, so that will basically hurt a lot. Let's move on to the splenic injury, because this is the major organ that a lot of people think about when they think of abdominal, abdominal hemorrhage or abdominal injury. So the most common risk factor is a patient who either has mononucleosis or has recently had it. Mononucleosis is caused by EBV, Epstein-Barr virus. and this results in an enlarged spleen. This enlargement is prone to rupture from relatively low velocity trauma. Sometimes spontaneous. Sometimes you don't even need trauma to have a splenic rupture. So the patient will present with left upper quadrant tenderness, guarding, sometimes rebound, and sometimes signs of intraperitoneal bleeding. So there's a couple signs that have been attributed to historical names. So Kerr sign is referred left shoulder pain in context of a ruptured spleen. That's mainly because the left hemidiaphragm gets injured and communicates with the left shoulder. Cullen sign is edema and bruising around the umbilicus, and you can see Cullen sign right here. And Gray-Turner sign is sign of bruising on the flanks, and this is a sign of retroperitoneal hemorrhage, which is right down here. So for a splenic injury, you want to image with a CT abdomen or an ultrasound abdomen. You want to admit to observation. For most pediatric patients, they may be non-operative and just basically observe them and make sure they don't get worse. Adults, though, they're less, resilient, so they may need splenectomy. So after splenic injury, the return to play is typically 3 months, and you want to avoid contact sports for 3 to 4 months. And this obviously we'll talk a little bit more about return to play later, but this is not set in stone. Usually there's a lot of managing risk and seeing whether 3 months is too soon or not. We're going to take a little aside about Epstein-Barr virus, just so that you're very familiar with it. And so EBV is really the culprit here for splenic ruptures. This is a double-stranded DNA virus from the herpes family, which means that once you get it, you have it for life. The lifetime prevalence is 90%. And it takes 4 to 7 weeks of incubation, meaning that if you kiss someone and they have Epstein-Barr, it may take up to 2 months for you to know that you got it, because you'll be sick and anywhere from a month later or 2 months later. So the question is, who have you kissed in the past 2 months? That'd be kind of a curious question to ask, but that's the way this virus is transmitted is through saliva. So this virus causes fevers, lymphadenopathy, pharyngitis. It's usually self-limiting, meaning that your body can fight it off with your own immune system. The complications are splenic rupture, hepatitis. Sometimes you can get airway obstruction from severely enlarged tonsils, and there are some patients who have chronic Epstein-Barr virus infection. This is mostly reported in Japan. There are some late complications. There's a pretty significant association with lymphoproliferative cancers with EBV. Multiple sclerosis, there's some association. In rheumatoid arthritis, there's a suspected association, but not confirmed. The problem with EBV is that it's so contagious that even after you get rid of it, technically you're still contagious up to half a year past your illness. So, this explains why almost everyone has been exposed to EBV. This virus infects B cells of the oropharynx, and basically 70% of adults or adolescents will have classic symptoms: fevers, pharyngitis, lymphadenopathy, lymphocytosis. There's usually some white tonsillar exudates, palatal petechiae, elevated liver enzymes, the ALT, and enlarging of the liver and the spleen. So if you suspect an infection with EBV, you need to remove the athlete from play. This is usually up to the physician who's taking care of the team. And removal from play usually lasts 3 to 4 weeks from the onset of symptoms. So how do you diagnose EBV? So there are some blood tests that are quite helpful. Checking a complete blood cell panel can help. There's a monospot test. If those two tests are negative, then you start trying to think if there's anything else that can present similar to EBV, such as HIV. Sometimes if you have a positive monospot test and lymphocytosis, you can confirm the diagnosis, or you can just make the diagnosis. But there's a viral capsid antibody, IgM, that can diagnose a patient with a monospot negative test as well. Again, as I mentioned, treatment is, there's no treatment that is curative for mononucleosis, and you want to give them supportive treatments such as analgesics, anti-fever medicines, hydration, and rest. So EBV can cause hepatitis, which can be quite severe. Hepatitis is inflammation of the liver, and it can increase the ALT levels up to 3 times the normal value. This doesn't last forever, it's transient. And there are rare cases of liver failure and chronic hepatitis with EBV, but most of the time you can expect some elevation in ALT. So this is what everyone worries about with mononucleosis, splenic rupture. And the spleen has a propensity to rupture because the architecture is altered during the infection. This is a rare complication without trauma, which is estimated 0.1 to 0.5% incidence. The first 3 weeks is really the highest risk for the patient with mononucleosis. And the highest risk of rupture is in sports such as martial arts, football, hockey, weightlifting, and other contact sports. So most of the time, non-contact activity is safe to return after 3 weeks, and then return to contact sports is less clear. Most physicians will feel comfortable clearing a return to play around 5 to 6 weeks, but in the literature, it's reported sometimes up to 6 months. Have a high alert in an athlete who had an illness in the past 6 months and participates in a contact sport. Such a patient, if they take a hit and, yeah, you know, I had mono 3 months ago, and all of a sudden they're lying on the floor because they had tackled and they have severe abdominal pain, they can still have, a risk of splenic rupture. Airway compromise is rare, but large tonsils can obstruct the airway. 1 to 3.5% of cases can cause airway compromise. This is mainly in young children, and they'll present with stridor, cyanosis, tachypnea, short breath. If you feel that the patient cannot breathe, remember your ABC, so airways first, and you need to send to hospital first because they will probably need systemic corticosteroids to decrease that inflammation. Tracheotomies are rare, but they basically can happen if there's complete obstruction in a hospital setting. Okay, so let's move on to hepatic injury. The liver is the most frequently injured abdominal organ. When you have hepatomegaly or hepatitis, this risk is also further increased. Right upper quadrant tenderness, nausea, vomiting, guarding, may have a Murphy sign, signs of hemodynamic compromise. All these things are signs that you have injured your liver. Murphy sign is basically a sudden stop of inspiration while palpating the right upper quadrant, mainly due to pain. We use Murphy sign more for cholecystitis, but you can still have it with a trauma case. You want to image with CT or ultrasound and admit for observation. Most of the time, 94% of cases, have normal hemodynamics, and it's non-operative treatment is fine. You want to avoid contact sports for 3 to 4 months, and you must be pain-free to return to play if you have a hepatic injury. And moving on to the third most likely organ to get injured is renal system or the kidneys. So this is like commonly forgotten. You need a high suspicion needed to diagnose. This is more common in children, just mainly because the ribs haven't covered completely the kidneys. The mechanism is direct blow to flank or sudden deceleration. And the patients will present with focal flank pain, gross hematuria. 25 to 50% of cases, however, do not have blood, visible blood in the urine. Sometimes you can have flank mass or flank ecchymosis. The labs are pretty basic, CBC, BMP, urinalysis, and HCG, which tests for pregnancy. You want to image with the ultrasound, a fast exam if possible, and a CT with contrast, which is called a pyelogram. That tests for lacerations in the kidneys. Kidney injuries rarely require surgery, mainly because they're retroperitoneal. They can contain the bleeding if there is a laceration. Most injuries will heal within 6 to 8 weeks. Even after you heal, you can still have microhematuria up to 4 weeks post your injury. And watch out for urethral injuries as well. So this is a paper from, I believe so they did a retrospective review focused on rugby. I believe this was in Ireland. And they wanted to highlight the fact that rugby is a very large sports in Europe. And they basically did a case series of 5 male patients, which does not seem like a lot in the span of about 6 to 7 years. But they had 5 male patients with rugby-related renal injury. One case had a pre-existing renal atrophy that resulted in nephrectomy after the injury, and this was due to a non-functioning kidney. The other patient had a small pseudoaneurysm, but no intervention was done. As I mentioned before, this was a case series just looking for kidney injuries, which just kind of tells you there's only 5 cases in about 6 or 7 years in one sport. This is quite rare injury to see. Here's another paper that I looked for renal injuries in terms of, this is a retrospective review. Approximately 245,000 cases each year worldwide. 82 to 95% caused by blunt trauma in the United States, and the majority of the cases are motor vehicle accidents or collisions or falls. So there's a small subset of cases that are caused by sports, blows to the flank, skiing, biking, or contact sports. So this retrospective review wanted to know basically that sports just have an isolated sequela polytrauma, an isolated trauma compared to polytrauma. So what they found is that they were focused on the high-grade injuries of kidneys, type 3, 4, or 5, and they identified 320 high-grade renal injuries from 2005 to 2014. So 18% of those injuries were due to sport, which is, quite small. 82% were due to non-sport. So most common sports were skiing, snowboard, and contact sports. And also there were younger male predominance in terms of cases. What they found is that there was no difference between the 2 groups in rates of hypotension, tachycardia, or hemodynamic instability. There was a difference, however, in the need for transfusion, less pelvic fractures, less thoracic injury or death in sports-related group, and there was shorter hospital stays. So there's evidence of lower injury severity in sports, which is what we kind of expected as well. This is another paper about focusing on the return to play after liver and spleen trauma. This was a clinical review. This was published in 2014. Most of the return to play decisions are based on low evidence, meaning that it's based on consensus and expert opinion. So this paper for spleen trauma recommended return to play anywhere from 6 weeks to 6 months, depending on the injury severity. This is a cross-sectional axial view of a CT scan. So this part is the liver and this part of the spleen, and you can see that this area here is where the spleen was lacerated. For infectious mononucleosis, 5 weeks to 6 months, as I mentioned before, is the return to play. This is without trauma and without rupture. Other factors to consider if you don't want to send the athlete back so soon is sometimes athletes will have excessive levels of fatigue, and often, they can persist even past 3 weeks, past the the time that you want them to return. Sometimes the athletes also may have persisting hepatitis signs. If they have jaundice, that would be a problem to return them. So you can always hold them out a little bit longer. Again, splenic rupture may still happen, even if you follow all the precautions. So, one of my questions is, how much are we fooling ourselves thinking that we can prevent it? I'm not sure, but at least we gotta try. When it comes to, the return to play for liver, there's even more scarce data on how to restrict from play. The literature and the historical way used to be based on serial CT scans to see if the liver is recovering. This is no longer recommended routinely, however. You can monitor the liver healing with normalization of liver enzymes on the blood to help your decisions. The range is about 3 to 6 months to return to play, depending on the clinical scenario, the severity. Here we have another CT scan from the same paper where you can see the liver and you can see the liver laceration here, which involves a relatively large portion of the liver. So again, this guy was run over by multiple dirt bikes in a race. You can see what the mechanism of injury was there. So how do you prevent abdominal injuries in sport? I think a lot of it has to do with making sports safer through policy, encouraging protective equipment, injury surveillance, depending on the high velocity, maybe placing velocity limits, although that may not be very popular. But basically, it's on the policy level that you can prevent more abdominal injuries. Splenic injuries are also seen commonly in snowboarders. In horse riding, tack failure, meaning the saddle and all the equipment that you put on the horse, can cause injuries. And again, handlebar trauma has been mitigated in children with a lot of padded protection of the ends of the handlebars. Okay, so we're gonna go to the last of the talk here with some practice questions. In a patient with abdominal trauma, microscopic hematuria should have urgent imaging of renal tract. Is true or false? Number 2, pancreatic rupture is easy to diagnose and commonly requires surgical management. True or false? Infectious mononucleosis increases the risk of splenic rupture. True or false? And pediatric age patients with confirmed splenic rupture without signs of hypotension will still require urgent splenectomy. True or false? And since we're going to hold off to participation, here are the answers. So number 1 is true, number 2 is false, number 3 is true, and number 4 is false. Well, a little bit more questions. Which of the following abdominal organs is not retroperitoneal? We got the kidneys, aorta, pancreas, bladder, and adrenal glands. And survey says the bladder. The bladder is intraperitoneal, technically. It's not retroperitoneal, so that would give it away. Which 2 organs are most common cause of abdominal hemorrhage due to an abdominal injury? And survey says you should know it is both the liver and the spleen. Liver and spleen. And question, the time frame most at risk of splenic rupture leading to during illness of mononucleosis is due to EBV is 1 week, 2 weeks, 3, 4, 5 weeks. And the answer is 3 weeks. 3 weeks is the period most risk of splenic rupture. All right, so we're pretty much at the end of the talk here. So these are my take homes. Sport-related abdominal injuries are, relatively rare, but important to consider. The first 3 weeks of mononucleosis is the highest risk of splenic rupture. liver and spleen are the most common organs injured that cause life-threatening bleeding. Again, transport quickly to hospital if you feel or detect signs of abdominal bleeding. And return to play decisions, there's low high quality data, and it's based on consensus and level of severity. For infectious mono, it's 5 weeks minimum. For spleen injury, 6-week minimum. For liver injury, 3 months minimum. And for kidney injury, unclear minimum, but 2 months minimum in my opinion. And that is all. All right, so Dr. Henny.
All right, we're back. So if anyone has any questions, thank you so much for speaking this evening. We ended up being somewhere right around 95 participants. So a lot of folks wanted to join us today. I think in part because potentially they're needing to submit hours to the VOC, but also it's certainly a relevant discussion to be had. So if you do have any questions for our speaker, please don't hesitate to put those into the question box and I can relay those on for you.
Yeah, I think I think this is the most relevant talk for downhill skiing, snowboarding, very high velocity sports. If you're ever going to cover these extreme sports, you can just make sure that you talk to your covering medical team and make sure that there's a plan in case they need to evacuate a patient due to either abdominal injury or any other kind of high velocity injury. Trauma is just one of those things that you need to have a plan in place before it happens and just prepare.
Okay, the first question comes from Shayna, and she asks, how can you safely tell that an athlete is ready to return after the 5-week minimum? Is there some type of readiness test or blood work?
If she's referring to infectious mononucleosis, most likely, I would say time is usually a good marker, and also how the athlete feels. I've had to return several athletes after infectious mono, and usually they're really anxious to return right around the 4-week mark. And that usually is in and of itself a clue to me that they're kind of ready to return, maybe overly eager. But usually what I have them do is at time frame of 4 weeks, I have them do non-contact physical activity, see how they're feeling, make sure that there's no abdominal pain. So you can have them do a light aerobic activities such as bicycle, low impact, and then you can have them start jogging, depending on their sport. And then you can have them do non-contact practice. And by that time, it'll be 5 weeks or more, and then they can go back to contact practice. And then just basically, you never really know, right? So as I mentioned before, you never really know if the patient is going to have a splenic rupture, even if you've waited the mandatory time. So the thing about talking to the athlete is, please let me know. You should tell the athlete, please let me know that if you have any abdominal pain, especially in the left side, that you need to let me know, because you're still at a slightly elevated risk of splenic rupture, even after waiting that mandatory period. But you're not gonna hold them out for half the year, then they lose their season. So it's kind of that's where the sort of the consensus and the art of medicine kind of comes in. And if you're an athletic trainer, you want to really work side by side with your physician and really kind of come up with a timeline. But usually the athletes will really want to go back. So that's usually a good way of finding out. If the athlete doesn't want to go back, then that tells me everything right now. They feel too fatigued, or they're looking sort of sickly, maybe anemic from an actual splenic rupture that has not been caught. So that's how I would approach that.
And then she did confirm after having mono. And her follow-up question is that 5 weeks from diagnosis or 5 weeks from the onset of symptoms?
Correct. And I did look into this in the literature. There's always that question because I always forget. And the answer is always from the onset of symptoms. So yeah, so sometimes if you diagnose a patient a week after they started feeling bad, their timeline really starts when their symptoms started. Many physicians will just pick the date of diagnosis, but I mean, that's not necessarily wrong. It's just sort of prolonging the time, and it may be safer. But in the literature, it just says from the time of onset of symptoms. Any additional questions?
It looks like those are the questions that we have. Certainly, if you have any additional questions, you can always reach out and we can forward those questions along. And so very good. Well, thank you very much. This was a great topic tonight. This was actually another topic that came from our previous attendees' requests and recommendations. So if for those athletic trainers who have attended, if you do have additional topics that you want us to find excellent speakers to cover those topics, please don't hesitate to put those into the surveys that you're going to receive in about an hour or so after these talks, because we will track down people to give those talks for you. But yes, thank you again to Dr. Sauceda coming to us today from California and giving an excellent talk.
Yeah, hopefully this was worthwhile for you guys.
Have a good evening, everyone.